But I did want to first of all ask Amanda Dines to come forward. It's important, given the commentary around an integrated force, that we have someone who can really tell us, someone who's lived that experience and as an exponent of it. And we all understand, as we've heard today, how health of all things, health and medical, the ADF simply would not have a capability, either domestic or deployed at times, were it not for the contribution of the part-time force. So Amanda's well placed, a medical graduate, deployed on operations in Iraq and Timor, commanded the Canberra Medical Unit and Health Services Wing, previously an Executive Director of the Royal Brisbane and Women's Hospital and Director of Medical Services at Redcliffe. So Amanda, fantastic to have you here with us to give us your perspective on this. Thank you.
Thank you very much, and it's a pleasure to be here today. I have to say I've gone old school. I have some palm cards. I've realised my pencil on a yellow background was a poor choice for my ageing eyes, but never mind, I will work through it. So I would like to go back to the beginning and just acknowledge the traditional owners of the land on which we meet. I live here in Brisbane and we acknowledge the Yagara and the Turrbal people. And I also would like to pay my respects to First Nations people who have been aviators, sailors and soldiers in our armed forces over the years and continue to serve. I'd also like, as a member of the United Services Club, to welcome you all here. For those of you who live in Queensland, particularly southeast Queensland, invite you to consider membership of the club. And if you're already a member but don't come here often, please do join us at events. It's a great place and it's a very collegiate environment. And I hope you enjoy your time here today. I have been in the Air Force now for 40 years and I've served both in the full-time force. Well, first of all, I was a medical undergraduate and then I served in the full-time force and for the last 16 years I've been in the part-time force where I've served both as CIRCAT 3 and I've held 2 CIRCAT 5 roles, one as the Clinical Director of Primary Healthcare and now as the Director General of the Health Reserve. So I really do feel that I have had the opportunity to experience that breadth of service. In the health domain of Air Force, we really are a joint force and we operate in an integrated fashion. The Defence Health Service is capability is led by the Surgeon General and dual-hatted with Commander Joint Health Force, who really leads us, and our operations are, and major exercises, as you know, are conducted out of Joint Operation Command, and they are always integrated in that sense. The health effect is integrated already, I believe. I served in Iraq, and as the senior medical officer to the United Nations forces there, and I was supported by 3 Navy medics and a nurse from the New Zealand Navy. The hospital in East Timor, when I served there, we had an Air Force command element, an Army Prevent Med element and radiology element, and a roster of specialists from Navy, Air Force and Army who came through to deliver that effect. And so was it throughout the whole of the campaign over the last 20 years in the Middle East. I guess it's not such a surprise perhaps, because although the environments, and I suppose that sort of we talk about being air-minded in the Air Force, and I guess in the Army you are land-minded and the Navy is sea-minded. So we bring a different lens to what we do through our home force. But, in the end we are dealing with the Mark I human. And you all bleed the same, you all breathe the same, and I think that really allows us to integrate very well. We also use a lot of the same equipment, and again that means that the way we can work together is pretty seamless. I think though that this this next phase, what the DSR offers us is an opportunity to do that even more seamlessly. And the other thing is, to integrate more seamlessly. And the second thing is to really pick up on the point I heard CDF made about us being a focused and integrated force. And I think really the work that we have to do in the health domain is to really think, what does focus mean? And we need to work with all of the rest of the Defence Force about what does a focused health effect mean. Because it's actually quite difficult to unpick, and getting a shared understanding about what that means we have and that we don't have is, I think, going to be very important. I think the other thing in the health domain that we have to look at very clearly is how this sort of fairly, not only we have an integrated force in a military sense, but we also almost completely have a shared workforce. So very definitely our part-time health workforce is shared with the civilian health sector. And that is both the public and the private sector. And we saw this challenge during the early stages of COVID around expecting to have to expand the intensive care capability in the civilian sector, at the same time when Defence was looking at, well, how is it going to be contributing to that national effect? And tensions, did arise in that space. So that shared workforce between military and the civilian sector is an important thing that we need to work at and understand. The other thing is that we share our workforce, not just even our deployable workforce, between those people who wear a uniform. The same people, as they do in other parts of the military, also work for non-government organisations and are part of the civilian response team in AUSMAT. And so we certainly find, in the deployment that the evacuation from Afghanistan, in the holding point in the Middle East, there were Air Force reservists there in civilian clothes working for AUSMAT, working alongside Air Force reservists and Air Force full-time people working together in uniform as part of that evacuation. And that can be really great if we want to integrate seamlessly our national capability, because we've got people who work in these different domains. But it can be really tricky if you're trying to figure out how many people you're actually going to be able to put to the task. Because if we're counting it in Defence and the civilians are counting on having that person for the reception in Darwin, and AUSMAT is counting on having them to move forward somewhere else, it's still only one body. So that, when I think about what is the work that we have to do in a force that does already integrate well, these are the sorts of things that we need to look at and unpick. Just to talk about the other things that we do. So in the Air Force Health Reserve, I have a sort of a diarchy with my the full-time Director General of the Air Force Health Service. She doesn't actually do that role full-time. She's dual-hatted with a full-time role in Joint Health Command, working for the Surgeon General. And so we work together to sort of deliver the health advice and optimise the health effect on behalf of Air Force. At an operational level, Air Force Health has an integration of the full-time and the part-time health workforce. This started 20 plus years ago when Health Services Wing was formed, headquarters now here in Amberley. Air Force has 3 health units, so a unit is the highest, largest group that we have. 2 of them are focused on air-based support and 1 focused on air evacuation. And our reservists are integrated together, and it's a joint unit. And what that means is that really does a number of things. It brings high-end specialist health capability to that effect, but it also means that, again, it's quite challenging for commanding officers and the units to manage their workforce. And 20 years down the track, it's still a work in progress. Interestingly, now with the formation of the Army Health Brigade, standing up the Army Health Brigade, I believe Army has really, moved to the same sort of structure where you have the part-time and the full-time force working together in integrated units to deliver the effect. And that's certainly a very, strong way to go, in my opinion, but one that needs just as much work as previous iterations where the two groups were fairly separate. At the strategic level, my team, I have a health reserve branch that has regional directors and then also directors in a variety of clinical domains. So I've got a director of surgery, a director of anaesthetics and intensive care, a clinical director of emergency, nursing, primary care, aviation medicine. You think, oh my God. So I have actually got quite a large team. And what that means that I've got people that can provide that technical input as well as the local input that Air Forces needs to husband its resources. We are also very challenged in recruiting, and I think we share your pain equally when it comes to some of those challenges of the complexity of the pipeline, but also the medical, the medical reviews that need to be done. And if you think it's complicated to get a high school sports champion through recruiting, well, let me tell you, if you're trying to get an intensive care specialist who's 45 on board, it's almost impossible. So, I certainly, I guess even though I'm on the health side of the fence, I certainly appreciate, some of those challenges. And, I think because it's in the specialist reserve, in the part-time health workforce, we have a lot of clinical experts that understand the military environment as well as the civilian environment. In fact, he probably doesn't know, but one of my important professional mentors as I came into the Air Force in the full-time force in Victoria was Peter Habsburger, who's sitting here at the front table. He's a cardiologist, and I just remember the quality advice he used to be able to give us when we were deciding if someone was fit to serve, to deploy, that sort of stuff. And that is the sort of advice that you still get from the reserve force specialist element. When you employ them, not necessarily to be hands-on tools. I don't think we need Peter out there doing cardiac work in the field, but when we employ them, not to do that hands-on work, but to use their deep understanding of the military environment along with their deep understanding of the specialist environment. So the reserve, I guess, from the Air Force perspective, is very integrated into, as I say, with our partners in the other services, but also between the full and the part-time force, with always the focus on how can we provide the best value and the best outcome and the best quality of input to Air Force and the broader Defence Force. So just a little advertisement for what we do. Thank you all and for listening, and I hope you enjoy your afternoon tea.
Amanda is happy to take a question or two, if there are any. There's some fascinating insights there, and I think the DRA has access to some extraordinary reserve health professionals like yourself, Amanda, and Peter has been mentioned. And I know people like Jeffrey Rosenfeld, of course, and others. So we'll be drawing on their insights because I think there's a great stock of knowledge and hard-won experience in terms of how to bring an integrated force together in the context of your service. So if there are there any questions? No. Thank you, Amanda.